Hello, it's a great pleasure to join you today for this meeting on ageing and health, even if it is electronically. I'm going to talk to you today about some of the ideas that are outlined in our World Report on Ageing and Health, which was released last year and which I will give you details for in the last slide. And I'm not going to start, as most presentations on ageing do, telling you about the demographic change that the world has currently experienced, the dramatically increasing proportion of older people and how that change is occurring faster in the past. The reason I'm not going to do that is it's maybe a very good way of engendering political interest, but it's actually a very bad place to start if you want to develop a comprehensive societal response. So I'm going to give you three potential places which provide better starting points for such a response. The first one is that older people have, just like everybody else, have rights that are firmly enshrined in international law. While many of us would like to see a convention on the rights of older people specifically, older people already have a right, for example, to the best attainable health. And that doesn't matter whether there's 2 billion of them, as there soon will be, or whether there's 2 of them. They still have that right. The second starting point is we're just entering a period where the world has coalesced around the idea of sustainable development goals. And if we're going to have sustainable development, that requires including everybody and ensuring that the contributions of older people, just as everybody else, are enabled, and that we make sure that they, just as everybody else, are not left behind. The third starting point is embracing the idea that older populations are very diverse. And this is something that the maps of the world and the demographics tend to overlook. They talk about people over the age of 60 or over the age of 65 as if that age group were homogeneous. But in fact, what we know is increasing diversity is one of the hallmarks of older age. So let me demonstrate that by looking at some data from the Australian longitudinal study of women's health. So this is a figure looking at physical capacity across the life course. And the blue lines you see here are the range of capacity. And you see that after childhood, the range actually increases. And even in low and very poor, low income and very poor countries, there are some people at the age of 80 who can still retain the physical capacity of somebody who is 20 years old. But you can also see from this figure how there are many people at even younger ages who actually have lost very significant amounts of capacity and require extensive care and support. We want to do what we can to make sure there are as many people as possible that are at the top of this curve, but we can't forget the needs of the people at the bottom. And so any societal response to ageing and health needs to consider this whole population, not just a part of it. Now, what's more, this distribution is not random. And so if you look across the life course, and here what we did with the data was to split it by quintiles of income adequacy, what you see is the people at the top tend to be those who across their lives have experienced various forms of advantage, whereas those at the bottom tend to experience disadvantage. And being at the bottom in older age is often the result of the cumulative impact of disadvantage across people's lives. And that means that the people at the bottom not only have the poorest health, but are likely to have the least resources and the access to the least resources to help them address the challenges that poor health presents. So as you look at this, you can see just how important the issue of health is if we're going to take action on older populations, and also how, as we do that, we need to take action that doesn't reinforce these inequities which have occurred across people's lives. So the World Report on Ageing and Health is focused clearly on what is healthy ageing, but in doing that it's tried to shift from a more traditional focus which defines healthy ageing merely from the absence of disease to defining it from a functioning perspective. And so this is the definition which we have used in the report, and which a month or so ago was endorsed by the World Health Assembly when it adopted the Global Strategy and Action Plan on Ageing and Health. So it says healthy ageing is the process of developing and maintaining the functional ability that enables well-being in older age. But while this may sound good, those words to us have very concrete meanings, and I'd like to take you through some of them so you can understand some of their implications. So what is functional ability? If you can think of a couple of older people, part of their functional ability is their intrinsic capacity. That is the person you see in front of you from their skin inwards, and the sum of all their physical, mental, cognitive and psychosocial capacities. But that's not the only thing that determines whether older people can do the things that are important to them. If I want to sit, for example, I need a chair. I also need assistive devices, reading glasses, to be able to read. And somebody who's had extensive loss of physical capacity can benefit by access to disabled access public transport to help them get where they want to go. So their functional ability and the functional ability of older people is a mixture of their intrinsic capacity and the various environments that they inhabit, and also the interaction between the individual and their environment. Now, if we go back to how we were thinking before about physical capacity across the life course and look at intrinsic capacity and accept that there is this growing diversity of within older populations. What you can look at, however, is unfortunately for most of us, as we age, our capacity does tend to decline. And if you look at any group of people in the second half of life, what you'll see is that most of that population can be put into one of three groups. People who have high and stable capacity, people who have declining capacity, and people who have had significant losses of capacity. The good news is that there's things we can do for each of those groups to improve their intrinsic capacity. And there's also things we can do to improve their functional ability. So, for example, for people with high and stable capacity, the key thing here is to preventing the onset of disease, to encouraging healthy behaviours, to identifying new diseases and treating and curing them as early as possible. And the key environmental contribution here is to the environments that can enable those positive behaviours, so for example physical activity, but also breaking down the barriers in those environments that can allow somebody with high capacity to continue to contribute. So for example, a classic example is mandatory retirement ages. If I'm in good health and I'm confronted by a mandatory retirement age, it can prevent my contribution and hence undermine my functional ability. For people with declining capacity, though, the focus has to shift. Health systems tend to focus very well on the first group. They tend to be focused on acute care and curing it. But in the second period, health systems need to be looking at how they can slow declines of capacity. And that requires not acute care, but chronic systems of care that can address complex conditions, and often more than one of them at the same time, because most people over the 65 actually experience more than one health problem at the same time. This is also a period where we need to shift the focus in terms of prevention. So there are things that you can do during this period which can also slow declines. And for example, an emphasis on resistance training and balance can help maintain mobility and muscle strength and so on. But this is also a time when the role of the environment changes, because here is when the environment can fill the gap that is presented by these declines in capacity and help people compensate for them, help people adapt to them. And so, for example, again, if somebody has declining physical capacity, access to disabled access public transport can help them get where they need to go when they need to get there. The third population group is a group where they have experienced already very significant declines of capacity. And this is a group who have extensive needs for care and support. And this is where long-term care becomes particularly important. Now, each of these periods, as I say, there are things you can specifically address to improve both capacity and ability. And with our Global Strategy and Action Plan on Ageing and Health, we've tried to identify a systems-wide approach as to how you might achieve that. So the Global Strategy and Action Plan identifies 5 strategic objectives. The first is a global commitment to action, and I'm very pleased to see that I think that is happening. The second is to ensure that every person has the opportunity to grow old in an age-friendly environment. Environments that can help them maintain their intrinsic capacity but can also help them compensate for losses of capacity. And again, here there's a lot of interest globally, and for example, our global network of age-friendly cities already has over 300 members representing well over 100 million people. The third strategic objective of the strategy is to realign health systems, to shift them from a focus on acute care that responds to individual conditions to systems that manage chronic conditions in an integrated way. And we call this older person-centred and integrated care. And that's a major challenge, particularly for the rich world, where there are entrenched systems and vested interests in maintaining them. The fourth strategic objective, and I think this is I'm so proud of WHO for emphasising the importance of developing systems of long-term care in every country of the world. Now, those systems don't need to be focused on institutional care, and in fact they probably shouldn't. They should be focused on trying to enable an older person to age in the place that's right for them. And in many cases that will be in their home or in their community. For some, it will be in an institution. And it doesn't mean that governments have to provide all of that. So, for example, a country in Africa which at the moment provides very little, what they would better be thinking of is a role in terms of governance and how they can bring together different providers, different stakeholders, make sure that gaps are filled, make sure that caregivers are supported, and making sure that the quality of the care that is provided is monitored and ensured so that older people are receiving care that's really appropriate. The fifth strategic objective is around much better measurement, monitoring and research in the area of ageing and health. And we have many knowledge gaps, and we need to take significant action to move that agenda forward. All of this may strike people as incredibly expensive, and often when people talk about expenditure on ageing populations, they talk about the cost and fret about how we can afford this, how will it be sustainability. And so we look at health systems, long-term care systems, providing lifelong learning and so on. But what WHO says is perhaps these costs are better interpreted as investments. And if you make an investment, you expect a return. And the return on these investments is very clear. For the individual, if you invest in health systems, in the appropriate health systems, you should get better health. If you invest in lifelong learning, you should enable older people to maintain their skills and knowledge and their relevance, for example, to the workforce, and so on. But these investments also result in a benefit to society. And that return could be in individual well-being, but also in a greater opportunity for workforce participation, in enabling the consumption of older people, and older people are big consumers in the economy, in fostering the entrepreneurship and investment that older people undertake. And it often surprises people to learn that the most successful entrepreneurs in the United States are people over the age of 50, not the youngsters. It can enable older people to continue to be innovative, to continue to make social and cultural contributions, and it can also foster social cohesion. And I think this comes back to the whole idea of the Sustainable Development Goals and fostering fair, equitable and cohesive societies. And if we make these investments, they have a broader return in terms of society's future. And this is a quote from the last page of the World Report on Ageing and Health. I think the last sentence captures what we are trying to achieve. That future is one that gives older people the freedom to live lives that previous generations might never have imagined. The World Report on Ageing and Health is not attempting to define what older people should do. It's not saying they should be in the workforce, they should be doing this or they should be doing that. It's looking at how we can give them the abilities to invent that future for themselves. So I would urge you all to have a look at the report. It's available online. There's also an academic publication that's associated with it in The Lancet, which can be accessed at this site. And I look forward to hearing how your discussions progress on what I think is an increasingly important issue for the world.